sir. We are live. We can start it.
Yeah, thank you. So, very good evening to all the doctors in the audience. Thank you very much for taking your time out, your precious time out for this wonderful session by Dr. Suvrat Arya. He is a consultant rheumatologist, MD, DM, currently practicing at JP Hospital, Noida, and his own clinic, Dr. Arya's Care Arthritis and Rheumatology Clinic at Noida. So I welcome you, sir, to this program and taking your precious time for us. And thanks a lot, sir, joining us.
Thank you.
Today, the topic of this webinar is very interesting and very much knowledgeable for all the doctors in the audience. The topic name is Approach and the Patterns of Arthritis. So I welcome you all to this initiative which has been taken by Zydus Synovia. I welcome you all to a Ruma DG Conclave. In the introduction of Dr. Suvrat Arya, I would like to give a brief introduction. Sir is a consultant rheumatologist, MDDM. Dr. Suvrat Arya is currently working as a consultant rheumatologist at JP Hospital, Noida, and Dr. Arya's Care Arthritis and Rheumatology Clinic, Noida. He has an illustrious academic career with many awards and gold medals. He completed MBBS from UCMC Delhi with a gold medal, and doctor did MD in internal medicine from PT BD Sharma PGIMS Rohtak. He then worked as a postdoctoral fellow for 2 years in Department of Clinical Immunology and Rheumatology at Christian Medical College, Vellore. He completed DM in a clinical immunology and rheumatology from the prestigious SGPG IMS Lucknow with the award of Best Resident Doctor among all specialties. He was selected for Indo-UK Fellowship and worked as an honorary fellow at Kinnock and Wolverhampton Rheumatology Centre, Royal Wolverhampton Trust, United Kingdom. He has numerous publications in national and international journals. He has contributed few chapters in various textbooks of rheumatology. So with this, I must say today we are having a young, energetic and budding rheumatologist, Dr. Suvrat Arya with us. Over to you, sir, for the session.
Thanks a lot. So I'll be sharing my screen.
Sure.
So is my screen visible?
Yes, sir.
Okay. So a very good evening to all of you. I'm Dr. Suvrat Arya, and I hope in this pandemic, the coronavirus pandemic, we all are safe at our homes, and I hope that this pandemic gets over soon. So today I am going to discuss about approach to arthritis, which is a very important topic as soon as a patient of joint pain comes to your clinic. He may come to a physician, an orthopedic surgeon, a surgeon, or a rheumatologist. But rheumatology is not a very widespread aware branch among people. So it is most likely the person or patient suffering from joint pain will come to a physician or an orthopedic surgeon before he knows that he has to come to a rheumatologist. So as a first point of contact, we must know how to approach an arthritis rather than just giving a symptomatic treatment in the form of painkillers or steroids. We should know how to make a correct diagnosis, because that will mean a correct treatment and a better patient outcome. So I am going to talk about the approach to arthritis under following headings, and then we will see how we can make a correct diagnosis in a patient who presents with joint pain and swelling. So firstly, we'll see what is the age and gender of the patient who is presenting with these symptoms. So it is very important aspect, a very important demographic character of a person who has polyarthritis. If it is less than 16 years of age, then it is a juvenile idiopathic arthritis, which itself is of many types. There are 5 types which are known. I'm not going to go into that detail because it is itself a huge topic. Connective tissue diseases like systemic lupus erythematosus, Sjogren's syndrome, or mixed connective tissue disease usually start in the females in the age childbearing age. So 20 to 30 is the usual age for starting of these illnesses. Then rheumatoid is seen when it starts in 20 to 50 years of age, but that doesn't mean that beyond 50 it cannot occur. It can occur, then we can call it as elderly onset rheumatoid. Ankylosing spondylitis, we all know the classification criteria for ankylosing spondylitis says that age of onset is less than 45 years of age, but usually now and then we see some patients who develop these symptoms beyond the age of 45 also. Degenerative diseases like osteoarthritis usually are seen in the elderly population, which is seen in more than 50 years of age. Diseases like pseudo gout, which is because of CPPD crystal, and polymyalgia rheumatica also are seen in the elderly population. So as I just told you, if it is more than 45, we call it as late onset spondyloarthritis. If it is more than 60, we call it as late onset rheumatoid arthritis. We all know most of the autoimmune connective tissue diseases have female predominance. Rheumatoid, around 3:1 is the female to male ratio, and connective tissue diseases like lupus have around 9:1 female predominance. But there are certain diseases which are dominated by males also. Ankylosing spondylitis and other spondyloarthritis type of diseases are around 2 to 3 times more commoner in females, in males, and gout is little more commoner in males, but after menopause, the incidence of gout in male and female is around same. And there are some diseases like pseudo gout, which have gender equality. Both male and females are equally affected. Then we have to see whether this is an acute arthritis or a chronic one. Acute means less than 6 weeks of duration, and chronic means more than 6 weeks. This division of 6 weeks has a significance. Then we also have to see what are the number of joints which are affected. So oligoarthritis or oligoarticular disease is the one in which 4 or less joints are affected. So if it is acute oligoarticular, that means a person has only 1 or 2 or 3 joints and less than 6 weeks of duration. We will call him as acute oligoarticular arthritis. The most common cause in our country is reactive arthritis. Reactive arthritis basically is an immune response mediating against an infective pathogen inside our body, but the immune mechanism lead on to inflammation in the joints. The joints do not have direct invasion by the bacteria or the pathogen. The most common infections which lead on to reactive arthritis are urinary tract infection and colitis, infective colitis. Then gonococcal infection is there, but this is becoming less and less these days because of widespread availability of antibiotics. Then we have to see about gout. Gout, we all know, it usually starts as an acute swelling of the first MTP joints. This presentation is seen in around 85 to 90% of patients. So acute presentation of monoarthritis of first MTP is classical of gout. Now let us see if it is acute presentation and a polyarticular involvement. Again, reactive arthritis is very common. Viral arthritis is common whenever we have outbreaks of chikungunya infection. Then we can see a lot of people who have polyarthritis during the episode of the inflammation. Post-viral arthritis, especially again in post-chikungunya arthritis, it is polyarticular kind of a presentation. Drug-induced arthritis is there. Certain drugs such as fluoroquinolones, antibiotics like tetracyclines and interferons, they can cause drug-induced arthritis. Then there is a temporal correlation. Diagnosis is not that difficult, and on withdrawal of the drug, there is improvement in the symptoms. Ponsets arthritis. A reactive arthritis to tuberculosis is called as Ponsets arthritis. So if a patient is on treatment for tuberculosis and the patient develops acute type of polyarticular or oligoarticular involvement, it is called as Ponsets disease. Then there is sarcoidosis, which usually is known to affect the ankle joints, but in acute polyarticular setting, it can affect the small joints of hands and wrist as well. Now coming to chronic oligoarticular arthritis. Now there have been some differences now between the acute and the chronic. You see the psoriatic arthritis has now moved up. Psoriatic arthritis, as we know, is a chronic inflammatory disease of the skin, in which around 15 to 30% of patients can develop arthritis. We're going to discuss psoriatic arthritis a little bit in more detail as we go on. Spondyloarthritis group of the diseases. These basically present with predominantly lower limb arthritis, but they can also affect the larger joints of the upper limb also. Osteoarthritis, we know the most common presentation is chronic bilateral knee pain or chronic bilateral hip pain. So it is a chronic form of arthritis which is oligoarticular. Then crystal arthropathies like chronic tophaceous gout or CPPD can present with chronic oligoarticular, and rarely Behçet's can also have this kind of presentation. Coming to chronic polyarticular arthritis, rheumatoid is the most common, and rheumatoid is the prototypic example for chronic polyarticular arthritis. Then psoriatic, peripheral spondyloarthritis, generalized osteoarthritis, which will affect both knees, hips, and small joints of hand, the base of the thumb or the tip of the digits, can cause chronic polyarticular. And then is the crystal arthropathy, like we can see in the gout and the CPPD. Now, this is probably one of the important points, whether the arthritis is inflammatory or non-inflammatory. We all know from our pathology days during MBBS, there are 5 cardinal signs of inflammation, which is pain, heat, redness, swelling, and loss of function. This loss of function and pain can be seen in degenerative type of arthritis also, like osteoarthritis. But these 3 points, pain, redness, and swelling, are important cardinal signs of inflammation. And most of the arthritis which we have discussed till now are inflammatory types of arthritis. And that is how we can narrow down our diagnosis. Sometimes there is confusion whether it is a degenerative disease or an inflammatory process. So this point can help us differentiate these. Now, we all use inflammatory markers. ESR and CRP are the most common ones. The important point is you have to exclude other causes of elevation of ESR and CRP. Suppose a patient has bilateral knee pain, but patient also had sore throat around 2 days back, and you do ESR and CRP, these will be elevated. So we have to see ESR and CRP in the context of that particular clinical scenario. And normal ESR and CRP also do not mean that inflammation is not present. Sometimes there is low-grade inflammation going on in the joints, which may not reflect in the serum investigations like ESR and CRP. So for inflammation, we also have the help of imaging, in which we can use radiography, which is the plain X-ray. Soft tissue thickening is very clinically evident, so radiography may not be very beneficial to document soft tissue thickening because it is obviously clinically evident. But erosions, yes, they can be picked up on radiographs. MRI may be picking up erosions little early, but yes, the classical description of erosions was given by the radiographs. Then is the crystal deposition. We know that the meniscal calcification in the knee joint can be picked up by a plain X-ray knee, which is a classical pathognomic feature of CPPD disease. Then what is the role of MRI? MRI can pick synovitis and synovial effusion when there is a suspicion of a subclinical thing. So if a patient complains of knee pain, patient complains of wrist pain, and on examination you don't find any swelling, any tenderness, but patient says I have morning stiffness also, then maybe MRI of the wrist joint will help you by telling you about subclinical synovitis. We all know for diagnosis of ankylosing spondylitis, which is the non-radiographic variety, that means when the disease is early or the X-ray changes are not there, then MRI can pick up bone marrow edema. And then the late entry is the power Doppler ultrasound, which is very handy tool, can be done in OPD. It is a very easy, radiation-free, real-time image giving tool. But the problem here is it is operator dependent. Something which may look like synovitis to me may not look like synovitis to someone else. So that is the drawback for the ultrasound. Now moving on, whether the disease is localized or systemic. Now this is the most important point of the entire discussion which we are going to have. Whenever a patient of joint pains come to you in your clinic or you see as an admitted patient, always try to ascertain whether it is a disease of the joints only or whether it is a systemic disease which is causing inflammation in the joints also, because it makes a huge difference to the diagnosis and the management. So I have put very salient brief points of what additional features other than joint pain you have to look for if a patient of arthritis or polyarthritis comes to you in your clinic. Never ever ignore skin and mucous membranes. Always look for rash or ask for these features. A patient who has acute onset rash on the face may be having human parvovirus B19 infection. This virus can also give an appearance of a slab cheek appearance like this you can see here. Now this manifestation is much more commoner in pediatric age group, but human parvovirus B19 infection can be seen in adults also. In adults, it can also cause bone marrow suppression and pure red cell aplasia. So it is also important to pay attention towards hemoglobin. Malar rash, we all know it is one of the classical signs of lupus, but again, malar rash can also be seen in B19 parvovirus infection, Lyme disease, rosacea, dermatomyositis also. We have to look for plaque and we have to ask for plaque particularly because these plaques or scales may not be present in obvious regions. It may be present hidden in the scalp or behind the ears or in the gluteal cleft also. So if a patient with polyarthritis have these, you should think about psoriatic arthritis. Then heliotrope sign is pathognomic sign for dermatomyositis, in which you can see there is violaceous bluish violet hue around the eyelids. Now this patient may also present with muscle weakness and elevated muscle enzymes. Then moving on, erythema nodosum is not easy to miss. When present, always look for sarcoidosis, inflammatory bowel disease, and a very important point which is not mentioned here is in our setting is tuberculosis. Then pyoderma gangrenosum is a chronic non-healing ulcer with a necrotic base, violaceous margins, and overhanging edges. Now, this kind of presentation, if a patient of polyarthritis has, always think of inflammatory bowel disease, especially if patient has weight loss, anemia, and has diarrhea. Rheumatoid also, uncontrolled inflammation can cause pyoderma gangrenosum. Sometimes lupus and spondyloarthritis group of diseases can also cause this symptom. Palpable purpura basically means leukocytoclastic vasculitis happening in the skin. It is a form of small vessel vasculitis to medium vessel vasculitis. It can be seen in hypersensitivity vasculitis, henoch-Schönlein purpura, which is now known as IgA vasculitis or polyarthritis nodosa. These may also be seen in Sjogren syndrome. Livedo reticularis can be seen in APLA syndrome, cholesterol embolization, and also in polyarthritis nodosa. Now, quickly, I will cover these. Keratoderma blennorrhagica is not difficult to miss because patient will have these scaly regions over hands and feet. They can be seen in reactive and psoriatic arthritis. Discoid lesions can be seen in lupus. Gottron's papules you can see here, also very difficult to miss because they are present in the regions which are easily picked up by the patient or by the physician. These are classically seen with dermatomyositis. For eye, I think most of us know if a patient has uveitis or iritis, it is either spondyloarthropathies or sarcoidosis or rarely Wegener's granulomatosis. If a patient has oligoarthritis of lower limb, always ask about past history of uveitis. Conjunctivitis is a less severe problem in the eye as compared to uveitis, and these are the diseases which can have it. Continuing with the eye, scleritis, always think of uncontrolled inflammation or vasculitic process due to rheumatoid. Ischemic optic neuritis, patient will present with sudden painless loss of vision. Always think of giant cell arthritis. Though it is not very common in India, it is a more commonly seen in European population, but still recently we have seen few patients. So it is not that it is not seen at all in our country. Oral ulcers, we all know we have to think about lupus. If there are painful multiple ulcers, think of Behçet's. Ask for genital ulcers also. And reactive arthritis and inflammatory bowel disease can also have oral ulcers. Parotid enlargement, Sjogren sarcoid. One more important thing which is not written here is HIV. If your patient has parotid enlargement, always do HIV test also. Macroglossia. So for defining macroglossia, you can see here, macroglossia means enlarged tongue. And you have to see that there are teeth markings present over the lateral border of the tongue. This is how we can ascertain that macroglossia is present. It is classically seen with amyloidosis. Then scalp tenderness and certain other ear manifestations you can see in other forms of vasculitis. Nails are very important. Never ever miss the nail examination. Onycholysis can be seen in psoriatic arthritis. We will discuss psoriatic arthritis in a little bit more detail. Pitting can be seen in psoriatic arthritis. Clubbing can be seen in inflammatory bowel disease or Whipple's disease and hyperthyroidism. Nodules can be present in rheumatoid arthritis, like in hair, or they can also be present in gout, which is hair. So what is the difference in these two? The nodules of rheumatoid arthritis are much closer to the olecranon process as compared to the tophi or the nodules of the gout. They are usually smaller and they are they are more softer and less firmer, whereas the nodules of the gout or the tophus of the gout is usually larger. It may be more firmer. The nodules of rheumatoid are not long lasting. They may disappear, but the tophi deposits may not disappear unless and until you give urate lowering therapy to treat the gout. Then if patient has history of jaundice, think of hepatitis, rule out chronic viral hepatitis like hepatitis B and C. And if a patient has hyperpigmentation, think of hemochromatosis or Whipple's disease. Now quickly, I will finish these. If the patient has telangiectasias, which are dilated small capillaries, like you can see all over the face, patient also has skin tightening and skin thickness, think of scleroderma or eosinophilic fasciitis. Hair thinning is a very common issue. It can be seen in hypothyroidism and lupus. If there are multiple tender points, it may be fibromyalgia. And then these are the various musculoskeletal manifestations which we are going to discuss when we see a few cases and how we diagnose them for the various diagnoses. Now, having covered the localized or the systemic disease, now we'll see patterns of involvement of the arthritis in various case scenarios. I have selected few cases which are commonly seen, encountered in our OPD, and these will give you a very fair idea of how to approach them. So coming to the case one, it is a 45-year-old lady who has polyarthritis of 6-year duration. It is a symmetrical small and large joint arthritis. The DIP joints are spared. Rheumatoid factor and anti-CCP is positive. So it is a chronic polyarthritis, symmetrical of small and large joints with 2 antibody positive. It means clearly that the patient has rheumatoid arthritis. Now, this is the 2010 ACR EULAR classification criteria for rheumatoid, in which they have removed the prerequisite for the previous criteria to have the symptoms for at least 6 weeks. Now, the problem with the previous criteria was the patient should have symptoms for 6 weeks, only then you can diagnose as rheumatoid. But now is the medicine of early diagnosis and early management. So they have, instead of making it a absolute mandatory criteria, they have moved it here and they have given a 0.0 if it is less than 6 weeks or 1 if it is more than 6 weeks. And according to joint distribution, you can give a point here. According to serology, you can give the points here. And if the total points are 6 or more, you can classify the patient as rheumatoid arthritis. Now here I will take 2 minutes to tell you that it is a classification criteria and it is not a diagnostic criteria. So what is the difference? Diagnostic criteria is the criteria used by a physician in a clinic on a patient to diagnose a patient as rheumatoid, whereas classification criteria are used by the various trials to enroll the patient into the trials so that they can have a homogeneous population of a disease while enrolling the patients in a trial. Classification criteria is not meant to diagnose a patient. The diagnosis of rheumatoid arthritis is based on the discretion of the treating physician. But classification criteria can help us guide in a way that, yes, these are the various points we have to look for before labeling a patient as rheumatoid. So this is how the hands of that patient looked. So you can see here, there is wrist swelling, there is swelling at the MCP joints, there is swelling at the PIP joints also here. There is volar subluxation happening at the MCP joints, and there are some deformities like swan neck deformity happening at the fifth digit in the DIP joint. And this is the X-ray of the patient, in which you can see that there are marked juxta-articular osteopenia. So there are no erosions present here right now, but this is juxta-articular osteopenia, and it can also be seen at the MCP joints and also at the PIP joints, and not at the DIP joints. So why does this happen? Because of the increased vascularity, increased blood flow, the first sign, the first change which happens in the X-ray in a patient of rheumatoid is there is juxta-articular osteopenia, which is also abbreviated as JAO. So this is the various clinical picture of various stages or various types of hand deformities which you can see. So the very classical one is that there is ulnar deviation happening at the wrist. You can see the hand appears to be deviated slightly towards this side. There is radial deviation at the wrist and ulnar deviation at the metacarpophalangeal joint. So you can see there, the fingers are going in this direction towards the ulna, whereas wrist is slightly deviated towards the radial side, that is the thumb side. Also, there is volar subluxation at the MCP joints. Here you can see extensive synovial swelling at both the wrist joint, and MCP PIP joints are also swollen. Now let's move on to case number 2. Here is a 30-year-old male who has polyarthritis for last 5 years, and his anti-CCP is positive. Now, listening to this short history seems like that this patient may also be rheumatoid arthritis, but this is how his hand looked. You can see there are certain scaly lesions with erythema in the center over the hand, and also he has nail changes, which was onycholysis present in most of the fingertip, most of the nails. And he also had involvement of DIP joints and also of the PIP joints. So when I asked him, do you have these kind of lesion anywhere else also? Then he showed me his abdomen, and this is what his abdomen looked like. And this extensive lesion is nothing but psoriasis. So this patient basically has psoriatic arthritis. How? He has a long-standing history of psoriasis. He has polyarthritis with DIP joint involvement, which is usually not affected in rheumatoid, and he has nail changes. These nail changes are usually associated with DIP joint arthritis. Now then, why it is CCP positive? CCP positive is the confusing thing here, because anti-CCP can be positive in around 4 to 5% of patients with psoriatic arthritis. So never go by the investigations alone. Always look for the clinical picture and the clinical context of the patient. So this patient also had extensive inflammatory changes of the psoriasis over his bilateral legs. And this is some other patient's photo, which shows the classical location of the plaque type psoriasis, which is usually present over the extensor aspect of the joints. Now, psoriatic arthritis can present as symmetrical polyarthritis, asymmetrical oligoarthritis, like we have already seen, spondylitis, which usually is asymmetric as compared to ankylosing spondylitis, and it can also involve DIP joint like in our patient. And the last one is the destructive form of arthritis, in which there is extensive damage to the joints and there is complete loss of joint function. So the most common type of presentation for psoriatic arthritis is the symmetrical polyarthritis. What are the clues? The DIP joint involvement, like in our patient, associated skin and nail changes. Always look for occult sites like scalp, behind the ear, umbilicus, and skin lesions may follow arthritis. Now, this is very important. If the pattern of distribution is looking like psoriatic and the patient doesn't have skin lesion, around 15% of patients, they have seen in various studies that they may develop psoriasis after developing arthritis. So the arthritis comes first and the psoriasis came later on. So this is how It may present in occult site. This is behind the ear, natal cleft, around the umbilicus, and in the axilla. So what are the differences between psoriatic arthritis and sorry, what are the differences between psoriatic arthritis and rheumatoid arthritis? Psoriasis is present obviously, but it is more asymmetric as compared to rheumatoid. It has enthesopathy. Enthesopathy means pain and inflammation at the site of enthesis. Enthesis is the site of attachment of your tendons and ligaments to the bone. So the various sites are behind the heel, below the heel, on the sides of the chest wall where serratus anterior is attached, below the tibial tuberosity, above the patellar attachment. These are the enthesial sites. Dactylitis means also known as sausage digit, which means the whole of the digit is swollen. Nail dystrophic changes can be present in psoriatic arthritis, which are not seen in rheumatoid, and it has association with HIV. So always, if a patient of psoriatic arthritis comes to you, always do an HIV testing. Now, how the X-ray is different from rheumatoid? First and foremost, see, there is no juxtaarticular osteopenia at all. The bones look okay, and there is resorption of the joint damage is extensive, and you can see it looks like whole of the digits is swollen. This is the soft tissue swelling. This is what a sausage digit is known as, and there is complete resorption of the DIP joint, and there is extensive inflammation happening here. There is shortening of the distal phalanx also. Here you can see that there is some periosteal reaction happening here, which is one of the classical signs of psoriatic arthritis. Here also you can see periosteal reaction happening. Psoriatic arthritis can also have erosions like rheumatoid, and these are the marginal erosions as they are in rheumatoid. This is how sausage digit or dactylitis will appear clinically when whole of the toe is swollen here and here also. Continuing with the X-ray of the psoriatic arthritis, you can see periosteal reaction and new bone formation. So here also you can see that beneath the periosteum it is lifted and there is new bone formation happening here. So this is how a periosteal reaction in psoriatic arthritis will appear, which is quite different what we see in rheumatoid arthritis, in which the predominant process is happening in the joints along with juxtaarticular osteopenia. Now this is how arthritis mutilans will appear. You can see there is complete destruction of all the joints of the hand. The hand function is lost, and this is also called as opera hourglass appearance. So now let's move on to our next case, which is case 3. 50-year-old male who has polyarthritis of 3 years duration. Now this next line is very important and will give you the diagnosis. He used to have monoarticular attacks which used to last for few weeks, and the monoarticular attacks when alternating first MTP joints. He also has history of renal stones. His rheumatoid factor and anti-CCP were negative. Probably in such a scenario, we may not have done rheumatoid and anti-CCP itself, but because it is chronic polyarthritis of 3-year duration, so maybe that is why patient had already carried this report with himself. But with this history only, the diagnosis is clear. The patient has polyarticular gout. So you can see this is actually a very extreme kind of a picture in which you can see large tophaceous deposits over the joints as well as in the subcutaneous tissue. Many patients with such huge deposits of gouty tophi will also tell you whenever there is skin abrasion, the chalky white material comes out of it. And if you take that material onto a slide and look at in the microscope with the polarizer, then you will see that it is urate crystals are present in the tophi from the material which is coming out from the tophi. So we have seen this image before also. Tophi can also be seen over the extensor aspect of the elbow joint. Now, how does the X-ray of gout is different from rheumatoid and psoriatic arthritis? Firstly, again, there is no juxtaarticular osteopenia, you can see. Then there is overhanging edges. So this area which is appearing here, actually a soft tissue swelling here of a big tophus must be present, which is not visible in the radiograph, and that is eroding into the bone, and that is why it is giving as a overhanging kind of an appearance. Here also you can see there is an marginal erosion, and here you can see there is a big soft tissue swelling, and this tophus, the soft tissue swelling here, may be encroaching or eating upon the bone, and that is why there is an overhanging bone margin with an erosion. So this is the classical how a gouty arthritis x-ray will look like. Now, like I told you, if you would have aspirated from the acutely inflamed joint of gouty arthritis or from the material which comes out of the tophus, you would see that there are needle-shaped, negatively birefringent crystals in a polarizing microscope. So usually the chronic type of polyarticular gout follows acute gouty arthritis attacks. 85 to 90% of people will have history of first MTP joint pain, acute onset inflammation and joint pain and redness. Around average of 10 to 11 years pass when the first attack happened and the patient develops a chronic gouty type of arthritis. The clues to the diagnosis is presence of tophi or history of previous gouty arthritis attacks. Now let's move on to our next case. He is a 60-year-old male, elderly male, who has polyarthritis for last 3 years. It is symmetrical. It is rheumatoid factor and anti-CCP negative, and CRP is elevated. Now, I would have thought that could it be seronegative rheumatoid arthritis? Yes, why not? Though age is more, he may be elderly onset rheumatoid, but let us see what we found in his X-ray. So there is a very subtle clinical sign which we are seeing here, which is called as chondrocalcinosis. Chondrocalcinosis means calcification of the meniscus present inside the knee joint, and this is one of the pathognomic signs of CPPD disease, calcium pyrophosphate dihydrate deposition disease. And these crystals are rhomboid shaped, which you can see here, and they are positively birefringent. So these rhomboid shaped crystals are positively birefringent. In hand, hook-like osteophytes can be seen in CPPD disease, in which you can see that there are hook-like osteophytes present inside the heads of the metacarpal bones. Now, this usually presents in elderly population, which is more than 55 years old. Less than 55 years of age, you should think about some defect in the metabolic pathway, or it is a genetic type of a CPPD which is familial. There are multiple metabolic diseases like hypophosphatemia, hypothyroidism, hypoparathyroidism, hyperparathyroidism, which can cause this kind of a disease in which there is defect in the phosphate metabolism. That is why this CPPD crystal form and get deposited in the disease and lead on to inflammation. This can very well mimic like rheumatoid. That is why it is also called as pseudo RA. It is also known as pseudo gout. It is also known as pseudo osteoarthritis and also known as pseudo polymyalgia rheumatica, because it can present with any of these manifestations. The clues will be typical calcifications of the various structures inside the joint, which we can see easily on a radiograph. Now let us, till now, whatever cases we have seen are those in which only joints are affected, and one patient had skin disease also, which was psoriatic arthritis. Now let us see a patient who has poly-organ involvement or a multi-system disease. Young female, 25-year-old, presented with fever, polyarthritis of 6 months duration. She also has skin rash. She tells photosensitivity. She has extensive hair loss, and you can see this kind of a rash is there. And she has, looks like she has hand deformities, but all these deformities are correctable. Rheumatoid factor was done thinking it is RA, and patient was labeled as rheumatoid arthritis. Now, what is the problem here? Young female having multi-system involvement, rheumatoid factor positivity, before labeling as RA, think of a multi-system disease which is common in this age. Think of lupus. So this was the face of the patient. She had photosensitivity and malar rash, and it is ANA was done, which was 4 plus homogeneous. dsDNA was elevated. She had proteinuria. Kidney biopsy was done, and she was labeled as SLE with class 4 lupus nephritis based on the biopsy. Now, why was rheumatoid factor positive? SLE is a prototypic autoimmune disease, and it is home of multiple autoantibodies. There is loss of immune tolerance, and you may find anti-CCP also, anti-Rho also, anti-LA also, and whole lot of autoantibodies in a patient of SLE. So if a patient of this kind of presentation has rheumatoid factor, don't jump to make a diagnosis of rheumatoid arthritis, because SLE is a very more deadly disease as compared to rheumatoid. Untreated class 4 lupus nephritis may lead to end-stage renal disease in around 50% of patients within next 5 to 10 years. And once that develops, then there is poor quality of life and high mortality. So always look for proteinuria in a young patient who has polyarthritis. Evaluate for other diseases if there is multi-system involvement. And we need not worry about joints then, because class 4 lupus nephritis will need aggressive immunosuppression, and that amount of immunosuppression will itself take care of the joints, because the dose of immunosuppression will be much higher to control lupus nephritis, what is needed to control for arthritis. So SLE is symmetric inflammatory polyarthritis, predominantly affects the joint distribution is almost same as rheumatoid. It is less inflammatory as compared to rheumatoid. The joints deformities are reducible. It is called as Jacobs-like arthropathy. Why? Because there is capsular laxity rather than erosion into the joints. So the capsule becomes lax, and that's why the deformities appear. But because the capsule is lax, you can reduce all the deformities. Usually it is a non-erosive disease. So these can be various clues to the diagnosis. Patient has malar rash, which is easily visible. Patient has photosensitivity, oral ulcers. Typically look also at the palate. These ulcers are usually painless. Patient may also have nasal ulcers. Look for alopecia, which may be non-scarring, or it may be scarring if it is discoid lupus-like lesion over the scalp. Also ask for history of serositis, and look for cytopenias in blood investigation. Also, very importantly, proteinuria. All these manifestations may not be present at the same time. Lupus diagnosis may be fulfilling the criteria over a time rather than at one particular time point. A patient may have past history of cytopenias, past history of ascites or unexplained pleural effusion, and now patient has developed malar rash and photosensitivity. All these points will have importance when making a diagnosis of SLE. Now moving on to next case, 42-year-old female, pain and stiffness of multiple joints for last 1 year. Rheumatoid factor came positive, again labeled as rheumatoid arthritis, advised steroids by physician elsewhere. But before patient started the treatment, someone told them why not to visit a rheumatologist, and then this patient came to me, and this is what her hands look like. So it is clearly not rheumatoid. It is sclerodactyly with skin tightness over the digits. There is osteoacrolysis, there is shortening of the distal phalanges, there is pseudoclubbing. Because of the resorption of the distal phalanx, the nails appear bent and they appear as if there is clubbing, and the hue of the digits is whitish as compared to hue of the skin of the hand. So this is basically patient also had history of rheumatoid, also had history of Raynaud's phenomena, also had history of stellate scars over the fingertips, and history of digital tip ulcers. So this is what classically would be systemic sclerosis. Patient had past history of skin tightening over the chest and abdomen also. Antibody showed SCL70, which is usually associated with the systemic sclerosis. Not every patient will have it, but SCL70 has association with diffuse type of systemic sclerosis, and this is how patient was labeled as diffuse systemic sclerosis and arthritis was just one of the manifestation of this systemic disease. Usually, patient present with arthralgia, pain and stiffness, erosive arthritis with joint space narrowing can be seen, but it is not in lot of patients. Commonly associated with calcinosis, which we can feel or we can see on the X-ray. Significant bone loss can cause osteolysis and skin contractures can happen. So this is how, because if this is the presentation, probably it is difficult to miss. Salt and pepper pigmentation occurring at the neck. You can see flexion contractures happening along with hyperpigmentation of the skin. Some pseudo clubbing happening here. This is some other patient who had come with gangrene of the tips of the digits and auto amputation of the little digit, and this patient also had salt and pepper kind of appearance of the skin. So when this is present, it is difficult to miss. But if there are subtle changes like only Raynaud's or digital tip ulcers, it may be easier to miss. So this is what subcutaneous or periarticular calcinosis will appear on the X-ray. So this is one of the classical features which are seen in very few diseases, very few rheumatological diseases. One is systemic sclerosis, other is dermatomyositis, in which such kind of dystrophic calcifications you can see. Now, the very important point which I want to emphasize here is never use high dose steroids in systemic sclerosis patient unless the patient has a worsening ILD or patient has significant myositis. Because if you use high dose steroids more than 10 or 15 milligrams equivalent of prednisolone, there is chances of scleroderma renal crisis. And even in today's time, scleroderma renal crisis has a very high mortality, up to 40 to 50%. So never use high dose steroids in a patient who is suspected of systemic sclerosis. Very low dose, or rather not using steroids, can also control arthritis. Steroids may be used in condition like ILD and myositis, maybe in a lower dose for a shorter time, and steroid sparing drugs may take over for the management of these diseases. Now, what are the clues which we have already discussed? Patient may complain of skin thickening, like you can see. There is puckering around the mouth. There are multiple dilated capillary loops on the face. There is pinched up nose, and the mouth aperture opening will be less. Patient may give history of Raynaud's phenomena, which is reversible change in the color of the digits on exposure to cold, and this color change recovers completely on rewarming. Raynaud's can also occur over the nose tip or the ear lobules or the toes of the feet. Now, this usually has three phases. It is pallor, that is white, followed by cyanosis, which is blue, and followed by rubor, which is erythema or redness. So this is pallor followed by cyanosis followed by rubor. So this classical triphasic Raynaud may not happen in everyone. Some may have monophasic or some may have biphasic. That means one or two phase of Raynaud's only. Then patient may have digital pit or digital ulcer. They may have telangiectasia over the extremities and over the face. And always look for pulmonary arterial hypertension and interstitial lung disease, which may be seen in these patients. PH may be more commonly in limited scleroderma, and ILD may be more commonly with the diffuse kind of variety of systemic sclerosis. Now, coming to rarer diseases which may present with polyarthritis, the one is mixed connective tissue disease. The arthritis develops in around 60% of patients. Severe erosive changes are usually absent. The changes may appear as Jacquard's arthropathy. Now, why it is called as mixed connective tissue disease, first of all? Because this disease has mixed manifestation of rheumatoid-like polyarthritis, lupus-like symptoms, myositis-like features, and scleroderma-like features. So these patients can have Raynaud's, muscle weakness, myositis, synovitis, arthritis, and all of them classically have high titer U1 RNP antibody positivity. In fact, U1 RNP antibody is the entry criteria to make a diagnosis of mixed connective tissue disease. Destructive arthritis is rare but can occur. The clues again will be Raynaud's, puffy fingers, very important, which I forgot to mention. If a patient has Raynaud's with puffiness of the fingers, like swollen digits, always think of mixed connective tissue disease, ANA must be positive in everyone, and ENA, or if you do separately ELISA for U1-RNP, high titer U1-RNP antibody will be positive. These patients may have myositis as well. Now, let us move to another important autoimmune connective tissue disease, which is even much more common in females as compared to males, which is primary Sjogren's syndrome. Most of these patients will have polyarthralgia, which is non-erosive symmetric. What can give you clue to the diagnosis of Sjogren is ask about symptoms of oral and ocular dryness. Uh, Classical teaching is look for dryness, but early in the phase of disease, dryness may not be present because dryness means the damage to the exocrine gland has already occurred. So we need to look for subtle signs of reduced salivary formation or reduced lacrimal gland function. Like if the patient is using eye drops, a patient carrying a water bottle to the OPD because he feels dry, ask the patient if he can take or eat food or a dry biscuit without water. These are the important clinical clue points which will tell you whether the patient has significant dryness of the eyes and dryness of the mouth. Because if you directly ask, do you have dry eye? They may say no. But if you ask, do you get up in the night to drink water? Do you need water during eating or while eating a dry thing? Then the answer may be yes. So this may be one clue when you are suspecting primary Sjogren's syndrome. Anti-CCP may be positive in some proportion of patients, around 7 to 10% of patients. Now, another disease which is still less common as compared to those which we have discussed is adult onset still disease. Initially, the arthritis may be mild, transient, and oligoarticular and may evolve into severe, potentially destructive polyarthritis. One of the characteristic feature is fusion of the wrist joint, which is earlier as compared to other joint, but it is not seen in everyone. It is characteristic, but not seen in everyone. The joint involvement is similar to what we see in rheumatoid arthritis. Important clue to diagnosis of AOSD is high grade fever intermittent. In between the fever episodes, the patient is rather asymptomatic, not ill looking. Lymphadenopathy and hepatosplenomegaly may occur. Patient may have serositis and sore throat. And there are a whole lot of skin rashes which can occur in adult onset celiac disease, from macular to papular to extensive rashes like shown in this image. So if a patient has high-grade fever with lymphadenopathy, hepatosplenomegaly, history of sore throat, antibodies like rheumatoid factor ANA negative, and a skin rash, AOSD should come in mind, but we must exclude infections because it comes in an acute setting with high-grade fever. AOSD is a diagnosis of exclusion after we have excluded viral infections like EBV or parvovirus or CMV or other systemic bacterial infections which can present with high-grade fever. Hand osteoarthritis. I have kept it down the line because it is a non-inflammatory arthritis, and rather I would say it is the most common cause of arthritis which is seen in our day-to-day practice. The clues are there will be bony enlargement of the DIP or the PIP joint, which are known as Herbeden or the Bocard nodes. You can see here elderly patient presenting to OPD with these kind of hand appearance, and these are bony swelling which are non-tender. Patient says, I have very mild stiffness in the morning or after inactivity. Now, very mild or minimal stiffness after inactivity is called as gelling phenomena, which usually lasts for less than 15 minutes. And as you start doing activity, it goes away, as compared to early morning stiffness, which is classically seen with inflammatory arthritis like rheumatoid arthritis. So when you will do the X-ray, you will see there is reduction in the joint space. The DIP joints are more affected. The base of the thumb is much more affected as compared to the other joints you can see here. And the classical feature is there is sclerosis. So rather than osteopenia, there is sclerosis, there is reduced joint space, there may be some bony joint deformity, no soft tissue swelling, inflammatory markers are normal, and clinical examination also shows bony swelling without any synovitis or synovial bogging. Now, this is what classically is called as seagull sign, in which you can see it appears as if there is a seagull drawn here. And this can be seen in diseases like generalized osteoarthritis, DIP osteoarthritis, hand osteoarthritis, and there is a term which is called as inflammatory osteoarthritis, in which there is rapid progression of symptoms with little elevation in the inflammatory markers. The first carpometacarpal joint, which is this joint, the base of the thumb, it is the most commonly involved. There is also what is called a squaring of the thumb. Bilateral involvement symmetrical with PIP DIP joint. MCP joint can be involved, but if it is prominent involvement other than these joints, always exclude other diseases. Viral infections, we have already discussed in the beginning. Chikungunya in the acute and the post-viral setting can mimic like rheumatoid. In fact, a lot of studies have shown after resolving of chikungunya, some patients may develop full-blown seropositive rheumatoid arthritis also. So probably in some genetically predisposed patients or persons, chikungunya somehow triggers the autoimmune response, and the immune system goes haywire and there is full-blown development of rheumatoid arthritis. Other viral infections like parvovirus, rubella, hepatitis C, hepatitis B can also mimic. So it is very important to look for at least hepatitis B and C in a setting before starting DMARDs, not only because it may be causing joint pain, also because the ACR recommends to do hepatitis B and C screening before starting conventional synthetic DMARDs like methotrexate. Now, infections like bacterial, usually it is a monoarthritis. If it is a septic arthritis, rarely in some immunocompromised patient, there may be polyarticular involvement. Usually it is seen with Staphylococcus aureus. Gonococcal infection can cause tenosynovitis and polyarthralgia or polyarthritis. Usually the larger joints are affected. Then mycobacterial infection, wrist joint can occur, or mono or oligoarticular involvement can occur with the mycobacterial. But commonly we also see that a pot spine is probably little more commoner as compared to peripheral arthritis, or larger joint monoarthritis may be little more commoner as compared to the small joint arthritis. So to finish and to conclude, there are a whole lot of causes of arthritis. Firstly, we must ascertain whether it is inflammatory or a non-inflammatory process, and then carefully look for extra-articular manifestation, any systemic examination findings, then go for investigation. And you should know before ordering the investigation, what if that investigation comes positive, rather than just blanket ordering some of the investigations. And then we can collect all the information together of clinical examination, history, investigations, and radiography, and then make a correct diagnosis and approach accordingly. Thank you so much.
Thank you so much, sir. Uh, Thanks a lot, and I must say it is one of the wonderful session and very insightful, wherein you have not only touched upon the rheumatoid arthritis, but you have touched upon the all the diseases which comes under the immunology and inflammatory diseases. So it was and it is really a very descriptive, I must say, and from all the aspects, not only from the diagnosis part of view, but from the treatment point, and very small points to be noted by the audience has been covered up. So I really thankful to you for this wonderful session, sir. With this, I would like to take you through some questions which has
Yeah,
been
yeah.
asked by the audience. The question is how to diagnose seronegative rheumatoid arthritis.
Okay. Yes. So if a patient has polyarthritis involving small and large joints symmetrically, and the duration of symptom is suppose 4 weeks or 6 weeks or maybe even more, and you order certain investigations like rheumatoid factor, anti-CCP, ESR, CRP, and the baseline investigations like hemogram, liver, kidney function, and other things are normal, rheumatoid factor and CCP come out to be negative. Now, in this scenario, before labeling as seronegative rheumatoid arthritis, always look that are there any extra articular manifestations which I am missing? Are there some features of the disease in which rheumatoid and anti-CCP can be negative? Is it like lupus? Lupus, rheumatoid factor can be positive but can be negative also. Is it lupus? Should I do ANA? is it psoriatic arthritis? Should I look for skin lesion? Or is it some infective process which is leading on to this kind of a reactive arthritis thing? So you should think about these questions. And then when you don't get any of these answers, then you can clearly label patient as seronegative rheumatoid arthritis.
Right, sir. Then there is one more question, which I think in connection with the first question.
Hmm.
How is anti-CCP better than the rheumatoid factor? That is the
Yeah,
question being asked.
yes. So rheumatoid factor was the initial one which was described, and it is basically IgM directed against FC portion of IgG. I'll say it again. It is an IgM antibody. Rheumatoid factor is an IgM antibody which binds to the FC portion of another antibody which is IgG. So rheumatoid factor is seen in around 85 or maybe 80 to 85% of patients with rheumatoid arthritis. It is same for anti-CCP also. The sensitivity of rheumatoid factor anti-CCP is same, but the major difference is the specificity. Anti-CCP is around 90 to 95% sensitive for rheumatoid arthritis as compared to rheumatoid factor, which is not a very specific test for rheumatoid arthritis. Now we can debate whether if the patient comes to you with polyarthritis, should you order rheumatoid factor alone or should you order both? Now, debate can have plus point from both the sides. I would say if there are severe financial constraints, you may order rheumatoid factor alone, and then you may go for anti-CCP testing if it is negative. If it is positive, it is fitting the scenario, you may label the patient as seropositive rheumatoid. But if patient is affording, patient can do it, or patient has already done and come to you, then there will be certain percent of patients whom anti-CCP can detect additionally, which rheumatoid factor would may have missed. So that is the benefit of doing anti-CCP over rheumatoid factor.
Thank you very much, sir. Thanks a lot. So these are the questions that we have received and well answered by the sir. These are the contact details I can see on the screen. So you may contact sir in case of any difficulty or in case of any query you may find in future also. Am I right, sir?
Yeah, it is.
And
That's fine.
yeah, so with this I once again say thanks to sir for taking his precious time on a working day, I must say. On the working day, and really hats off to you, sir, for such a wonderful session and such an insightful session, I must say, with all the case studies and with your personal experience you have put in. So with this I take a leave from this program on behalf of sir as well. So
Yeah.
good night to all, and thanks for joining today. Thank you very much, everyone.
Thank you. Thank you, everyone. Okay.
Thank you, sir.
Okay.